Thanks very much to the organizing committee for the invitation to come and speak with you today about some of the work I've been involved in around translating exercise interventions in the community with adults aging with HIV. The session I've kind of organized into 6 compartments. First, to provide a little bit of a background on this concept of episodic disability and aging with HIV, followed by the role of rehabilitation, some of the evidence on exercise, followed by an overview of some of the literature about what the state of physical activity is in the context of HIV, share with you some of our preliminary work with an intervention study looking at the effect of community-based exercise interventions in the community, and wrapping up with some practical considerations around exercise prescription and some work with a collaborative I've been involved with. So as we know, as individuals are living longer and now aging with HIV, the effects of chronic inflammation, long-term effects of treatments and aging, they are living with potentially the physical, cognitive, social, and emotional health challenges associated with HIV. And some qualitative work resulted in adults living with HIV conceptualizing these health-related challenges as something called episodic disability, characterized as multidimensional and episodic in nature, characterized by periods of both wellness as well as some periods of illness. The dimensions of disability or episodic disability include physical, cognitive, mental, and emotional symptoms and impairments, difficulties carrying out day-to-day activities, challenges to social inclusion, as well as this concept called uncertainty or worrying about the future, wondering when a next episode of illness might arise and what the consequences of that illness might be. This uncertainty is really established as a key component of disability, and we've done some work using some modeling with results of a national web-based survey. And this is a busy slide, but the take-home message is that uncertainty is a strong predictor of having mental and emotional health challenges, and also is a direct and indirect predictor of having challenges to social inclusion, even when you remove things like the physical and cognitive health challenges from this model. This concept of uncertainty has been explored specifically from the perspective of adults, older adults living with HIV, that have identified some issues around uncertainty of the source of health-related challenge, the episodic nature of HIV, also facing uncertainty alongside various healthcare providers who are learning as we all go along with respect to this work, the financial uncertainty as individuals transition into retirement, concerns around finding appropriate long-term housing, and for those who are caring for loved ones, also wondering who will care for me at the time when it comes in need. Participants in this particular qualitative study did not discuss about challenges in isolation, but also the contextual factors that occur in the environment, but also intrinsic within, that could exacerbate or alleviate dimensions of disability, such as social support and stigma, living or coping strategies, and as well as personal attributes such as aging and multimorbidity. So if we're thinking about exercise interventions, these ones here circled are modifiable contextual factors. So we might think about how these particular factors might influence not only disability, but one's ability to engage and sustain engagement in physical activity over time. This is just an example of what one participant considered their experience of living with HIV over time is. And this just demonstrates that episodes can be more major and influenced by those contextual factors, but also the day-to-day fluctuations or good days and bad days in one's health as well. So rehabilitation, such as physiotherapy or occupational therapy, has a role in addressing or preventing episodic disability experienced by adults living with HIV. It's defined as a dynamic process that includes all prevention or treatment activities or services addressed at targeting those different dimensions of disability. It's very broad. It can be involved at any stage of the continuum of care. It's client-centered and goal-focused. And what's really great about sessions such as today over the next couple of days is that we're really seeing how the fields of HIV, geriatric medicine, rehabilitation and primary care and other professions are now all merging together. Results of this web-based national survey found that despite the role for rehabilitation, very few are actually accessing formalized rehabilitation services. Respondents to this survey stated only 17% had access to physio in the past year, 6% an occupational therapist, and 3% a speech-language pathologist. Despite not accessing formalized services, 37% reported engaging most or all the time in exercise, and this was similarly found across different age groups in the sample. So exercise seems like a good living strategy within a self-management framework to address issues related to HIV and complex multimorbidity. I've had the opportunity to be involved in a couple of systematic reviews looking at the effectiveness of exercise, both aerobic and resistive, among adults living with HIV. And there's high-level evidence to suggest the safety and benefits of such. These reviews included 24 and 20 studies of aerobic and resistive exercise, respectively, with 14 studies including both a combination of aerobic and resistive exercise. Age of participants ranged from 30 to 49 years of age. The majority were men. Interventions ranged from 5 to 52 weeks, and the majority of these interventions were supervised. A few of the highlights of the results of this work indicated that there were statistically significant and potentially clinically important improvements in cardiopulmonary fitness, or VO2 max, among exercisers compared to non-exercisers. There were significant improvements in body composition in the form of arm and thigh girth and leg muscle area, which was considered an increase in muscle mass and strength among those engaging in resistive exercise versus no exercise, or combined exercise versus control. And also significant and again clinically important improvements in upper and lower extremity strength among those engaged in resistive exercise versus those only engaging in aerobic exercise. And lastly, while there were only 2 studies that we could combine in a meta-analysis that used the SF-36 to look at quality of life, there were statistically significant improvements in 6 out of the 8 of the SF-36 domains, but potentially clinically important improvements seen in mental health, role emotion, and physical function domains as well. So in conclusion, exercising approximately 3 times a week for at least 5 weeks is safe and can lead to benefits in cardiopulmonary fitness, body composition, strength, and quality of life. Now, despite some trends that would suggest improvements in CD4 count, ultimately the majority of meta-analyses still demonstrate that there's no differences in changes in CD4 counts and viral loads with respect to exercise. And we were not able to do any subgroup analysis that looked at comparisons of the effects of exercise among older versus younger adults living with HIV. Now, there's been some other great work looking at other health outcomes, such as neurocognitive health. And while neurocognitive health may decline over time, there has been some associations with improved neurocognitive health outcomes seen among individuals engaging in consistent physical activity versus no or inconsistent activity. As well, community-dwelling adults 50 years of age and older with self-reported physical activity of moderate intensity had shown associations in having less neurocognitive impairment and less impairment with those instrumental activities of daily living as well. Looking at metabolic outcomes, Kushla Ford and the team at St. James's Hospital in Dublin has looked at the impact of physical activity as measured by an accelerometer with respect to metabolic syndrome, and found an association there with people living with HIV and people not living with HIV. And Melissa Wilson, who will be presenting a little bit later, has done some great work with Christine Erlandson looking at the impact of both moderate and high-intensity exercise with respect to metabolic outcomes. And then there's been some work done looking particularly at strength training and finding not only improvements in strength, but some associations with decrease in inflammatory markers in exercisers versus non-exercisers. And sleep health and hygiene, which is first and foremost on many of our brains these days, as there's also been some associations, not surprisingly, that physical activity is associated with better sleep health and hygiene. And for others, looking at the ways in which I think we track sleep health and hygiene, found maybe not some associations with sleep health, but associations with decreased levels of fatigue, with Alison Webble. Now, one question to think about is all exercise equal? And there's been great work by Chrisanne Orsler looking at the difference of high versus moderate intensity exercise, which found improvements in exercise endurance as well as 6-minute walk test distance. But increases in VO2 max were seen with the higher intensity exercise group alone. Again, Christine Erlandson has also looked at the impact of high versus moderate exercise in older adults living with HIV and HIV-negative controls, and found fantastic adherence rates in both intensity groups and also improvements in physical function, but with slightly greater improvements found in the high intensity group. So at the end of the day, we know that exercise is beneficial. There's been some evidence formed in guidelines that have been established looking at rehabilitation interventions for older adults living with HIV. And exercise, both aerobic and resistive, are at the forefront of those recommendations. So exercise works, but essentially how many older adults living with HIV are actually engaging in exercise or physical activity? Now, this was an article published in The Lancet last week that looked at global trends of insufficient physical activity among the population. And there was a prevalence rate of insufficient physical activity of 27.5%. And the prevalence rate of physical inactivity tends to be higher in women and among those living in high-income countries. So when we think about the field of exercise as medicine, it really begs the question of what is physical activity and what is exercise? And how do we use those terms? With physical activity defined as any bodily movement that results in energy expenditure versus exercise, which is a planned, structured, and repetitive form of activity with the goal of improving or maintaining fitness. I had the opportunity to work with some physiotherapy students who did some qualitative work examining what the perceptions are between physical activity and exercise among adults living with HIV, who've conceptualized these terms as a continuum, involving health-promoting behavior that should essentially be a greater priority for them as they were aging with HIV. There has been a lot of variability reported in physical activity and inactivity levels in the literature among people living with HIV, ranging from 19 to 73%, as well as a recent systematic review by Van Kamfort, who found 51% reached the physical activity guidelines of 150 minutes of moderate to vigorous activity a week, but also not quite reaching that benchmark of 10,000 minimum steps per day. Similarly, Van Kamfort looked at correlates of physical inactivity and found that older age, lower education level, lower CD4 count, antiretroviral exposure, and lipodystrophy were associated with more physical inactivity. Not surprisingly, some barriers included pain, depression, and opportunistic infection, whereas facilitators of physical activity were higher cardiorespiratory fitness, higher self-efficacy, motivation, and perceived benefits. So some of the considerations to date, particularly those RCTs that we included in those systematic reviews, they're based on the inability to blind participants to the intervention of exercise, and they're also based largely on participants who completed the exercise interventions. They were primarily young men with little multimorbidity. The work is primarily done in resource-rich countries in highly supervised settings by highly trained personnel. So the question is how do these benefits actually apply to people living with HIV who might be of older age, and how do these interventions translate to the real-world community setting? This brings us to our work that's been done. I have an opportunity to work with a team and in collaboration with the YMCA in Toronto, looking at the effects of translating a community-based exercise intervention with the goal of reducing disability and enhancing health outcomes and contextual factors among adults living with HIV. This is an interrupted time series study design where all participants are followed for a baseline monitoring phase of 8 months, upon which there's the interruption. Participants are introduced to an intervention where they're provided a YMCA membership for 6 months. They're asked to exercise 3 times a week for approximately 90 minutes, including a combination of aerobic, resistive, balance, and flexibility training. That exercise is supervised once weekly by a certified fitness instructor. They're also provided a Fitbit Zip to track physical activity and invited to monthly educational sessions as well. At the end of the 6-month intervention phase, participants have their YMCA membership renewed for another 8 months. They're still expected to engage in their 3 times a week exercise, but they do not have access to the fitness instructor or the educational sessions in order to determine what the sustainability or the uptake of the exercise is over the long term. The data collection occurs over this 22-month time frame, and participants engage in bi-monthly self-reported questionnaire and fitness assessments, including VO2 max, strength, weight, body composition. We also have assessments involving something called the HIV disability questionnaire that assesses self-reported prevalence and severity of disability across the 22 months. And at baseline, post-CBE intervention and study completion, participants also complete a goal attainment scale and the neurocognitive assessment using the NIH Toolbox app. In addition to the quantitative assessments, we've conducted interviews at baseline, midway, and post-CBE intervention as well to gain perspectives on experience with exercise and perceived changes with respect to outcomes with the intervention. The goals of participants at baseline were very variable, ranging from wanting to improve aspects of one's physical health, but also a huge component around wanting to boost mental health and mood as well. Some of the qualitative work at baseline, participants talked about their anticipated or expected benefits with the exercise, boosting mental health linked to engaging in a routine, reducing fatigue, and improving sleep health. They looked forward to engaging in a structure and routine, having access to a one-on-one personalized fitness instructor who could get them on an exercise regimen. And they had huge intentions around adhering to the intervention. With respect to any anticipated concerns, there were some concerns about the ability to adhere to the thrice-weekly exercise among work, family commitments, and potential episodic fluctuations in health. But despite the probing, many participants really looked forward to engaging and were very committed to the extensive nature of the study and the intervention. This is a very busy slide, but the take-home message is, at the end of the day, there were 80 participants who reached the baseline level of the intervention. And among the 80 participants who initiated the intervention phase, 67 or 84% completed. Among the participants who were given a Fitbit, currently there are about 55% that still have the Fitbit. And to date, we have 27 participants that have completed the entire 22-month study, and there are 30 who are still in that follow-up and monitoring phase. So some of the very preliminary characteristics that I'll share with you is that the median age of participants is 51 to 52 years, primarily includes a sample of men, living with a median of 4 concurrent health conditions in addition to HIV, the most common being self-reported anxiety and depression and pain. About a third of the participants were working either full-time or part-time, and a third of the participants had some form of exercise history. They were either currently exercising or had done so in the past. This slide demonstrates the adherence to those weekly coaching sessions with their personal trainer. In blue was the 6 months of the intervention phase, and there were 29 participants who had episodes such as health reasons, travel, work, a change in coach, or communication issues that had required them to step away from their weekly coaching sessions, and then they supplemented and made up for them after the intervention phase as they transitioned into their follow-up. The median number of sessions attended throughout were 18 out of the 25 sessions. Among those monthly educational sessions, I mentioned participants were invited to 6 of these educational sessions. You can see the various topics there. The attendance ranged from anywhere from 14 up to 42%. And for participants who didn't feel comfortable engaging in an in-person educational session setting, we video recorded the speakers and participants could access them on our YouTube channel as well. Some of the self-reported physical activity measures among participants were that about a third and slightly higher proportion post-CBE intervention reported that they currently exercised regularly and had done so in the past 6 months. A greater proportion of the participants at CBE completion also reported exercising 3 to 5 days a week. We measured self-reported physical activity using something called the Rapid Assessment of Physical Activity, or the RAPA score. And 75% of participants at intervention completion were considered aerobically active. And also a greater proportion at study completion reported engaging in both strength and flexibility. And the majority of participants, both at the start of the intervention and the end of the intervention phase, expressed intentions on continuing to exercise 3 to 5 times a week. These are some very preliminary data from our earlier pilot work that we did looking at a 4-month community-based intervention. And after a 4-month exercise intervention, similar to the one in this study, fewer participants rated having severe overall disability at CBE completion. The HIV Disability Questionnaire has 6 domains looking at the presence and severity of disability, and the highest presence and severity of disability is in this uncertainty and worrying about the future. And this demonstrated some reductions post-CBE intervention, both in the uncertainty domain as well as challenges to social inclusion and overall HDQ scores. Again, this is pilot data, so very small sample sizes. And similarly, we saw some improvements in the physical health and mental health summary scores of the SF-36 post-intervention as well. So some of the preliminary reflections: the majority of participants in this sample are men. They're very highly motivated, median age of 51 years, living with 4 other concurrent health conditions, primarily self-reported anxiety and depression. The 84% who initiated completed the intervention, and there are a number of reasons why individuals needed to step away from their exercise regimen and then pick it up later in relation to episodic conditions or work or travel commitments as well. So some of our reflections to date is that episodic health meant episodic exercise, and this particular study seemed to symbolize a new beginning and offered a new structure and healthy routine for many of the participants involved. We used an implementation science approach, and so our research procedure was really intertwined with the intervention. The participants engaged quite frequently with the research staff, as well as the YMCA staff conducting fitness assessments, which served as an influencing and motivating factors for some for engaging and sustaining their participation in the study over time. And we often ask ourselves the question, does this need to be HIV specific or not? And to date, our reflections have been that HIV itself or alone appears to have less of an influence on level of engagement in the effect of exercise. Rather, it's the complexities that come with living with an episodic illness, mental health issues, and the complexity of personal and environmental factors that seem to emerge more strongly as influencing factors about one's ability to engage and sustain engagement with exercise over time. So some considerations moving forward around exercise and physical activity prescription. There's a number of different barriers and facilitators to engaging in community-based exercise. And I've had the opportunity to work with some physiotherapy students who have done some great qualitative work looking at factors to consider when developing these types of interventions that we've used to model the intervention in this work. Others have explored what the experiences of participating in the exercise intervention has been from the perspective of adults living with HIV. And lastly, I think one important consideration is around readiness to exercise, and at what point is someone ready to engage and initiate in an exercise intervention. This group of work was done to develop a framework of readiness to exercise among people living with HIV and complex multimorbidity that ranged and was influenced by levels of social support, perceptions and beliefs about exercise, past experience with exercise, and accessibility. So if you think about our YMCA study, a third of the participants had a previous engagement in exercise, and they all had accessibility with the YMCA membership and access to a personal trainer with respect to this intervention. Is all physical activity considered equal? We have very similar ACSM guidelines, Canadian Physical Activity Guidelines, and World Health Organization that all recommend this 150 minutes of moderate to vigorous activity per week, adding a couple of days of muscle and bone strengthening. And this is very similar for adults aged 18 to 64, and for older adults, the added caveat here is that for those with poor mobility, they should perform physical activities to enhance balance and prevent falls. Some of the considerations, I think, as a physiotherapist when thinking about prescribing exercise is we think about what are the goals associated with the exercise or physical activity. I think we tend to now recommend a combination of both aerobic and resistive training, but important to consider what the frequency, intensity, time, and type of that activity is and how one might progress or change that activity over time. As mentioned, the intrinsic factors such as motivating features, other aspects such as aging, frailty, and other health conditions, and how that might influence readiness to start exercise or stay exercising, as well as the extrinsic factors around accessibility and social support are very important as well. I think also important to consider are the functional outcomes. Very important, disability is very near and dear to my heart, particularly that we've been using with this HIV disability questionnaire, and I'm very interested in the concept of uncertainty and how these community-based interventions might affect or address uncertainty living or aging with HIV over time. And other features to consider as well are things such as diet and sleep health. And lastly, for those who have access, there is a role for physiotherapy with respect to exercise, being goal-oriented, client-centered, being featured around outcomes of interest, and it offers an ongoing level of support and can be tailored with other concurrent health conditions as well. We just celebrated World Physiotherapy Day last week, and there was a big campaign around the role of exercise when it comes to mental health. And interestingly, when a group of students I work with interviewed a number of health providers, some rehab professionals and other adults living with HIV, it was the adults living with HIV who recognized the role of exercise and physiotherapy in mental health, but not necessarily the physiotherapists, which we get very little training actually. So hopefully that trend is changing as we see with respect to some of this work here. And this is a framework around the role of physiotherapy in interprofessional HIV care that a group of students worked on. And I think this circular piece really identifies some of the unique or novel features among those aging with HIV to consider, not only when we think about rehabilitation, but interaction with any healthcare providers, as well as engaging in physical activity. So some final thoughts and some opportunities for partnerships. I have the opportunity of being involved in something called the Canada International HIV and Rehabilitation Research Collaborative, or CIRC for short, and it includes just over 80 researchers, clinicians, people living with HIV, and representatives from community-based organizations that started a network with an interest in translating knowledge around research in HIV and rehabilitation, as well as identifying new and emerging research priorities. And this is some work that we did as part of our first forum to identify where some of the emerging priorities were, and aging across the life course and concurrent health conditions were first and foremost center as well. We've had the opportunity to have a few forums to meet together. A number of people in this room have presented at past forums, and a few of them have focused specifically on aging with HIV. Most recently, we met in Toronto in June, and we had a few members here from the US present on yoga interventions, the effectiveness among yoga among people with HIV and peripheral neuropathy, social connectedness and community engagement, and Julian's also presented his work on frailty, not only at this forum, but past conferences as well. For those of you that might find yourself in the UK later this fall, there's going to be a Broadening the Lens symposium, looking at what we can learn from other complex chronic conditions to work towards successful or healthy aging around HIV. So in summary, I think given the complexity around episodic disability and uncertainty with HIV and multimorbidity, there's a role for rehabilitation. There is strong evidence to support the benefits of exercise. Community-based exercise offers a particular strategy that involves a self-management framework, but there are considerations around episodic disability resulting in episodic physical activity, and I think important to consider the physical, educational, and social components of those interventions as well. And lastly, if anyone's interested in learning more about the collaborative, feel free to touch base with me at any point throughout the couple of days. I think it's really exciting to see the work being done here and new opportunities for collaborations in this field. I'd like to just acknowledge many of the different colleagues and partners that I've had the opportunity to work on in the work that's been presented today here, and the funding for this work that has been provided through the Canadian Institutes of Health Research, or CIHR, their HIV research initiative. Thank you.